Okay. Okay. Um, Hello, everyone. Welcome to the White Army Comprehensive Clinical class. The White Army is privileged to have Dr. Radhika ma'am, Associate Professor, Bangalore Medical College and Research Institute, as a mentor today. Welcome to you, ma'am.
Thank
Uh,
you.
Ms. Rekha, third year MBBS student from BGS Gyms, Bangalore, has volunteered to present a case on fibroid today. Welcome to you.
Thank you. Good evening,
Welcome
ma'am.
to all the attendees to the session. With our mentor's permission, we shall begin the session.
Yes, we'll
Over to you,
start.
Ms. Rekha. Over to you, Ms. Rekha.
Thank you. Good evening, ma'am.
Good evening, Rekha. Start.
Will I start, ma'am?
Yeah, sure.
Good evening, everyone. Today I will be presenting a case of clinical case on fibroids. Presenting a case of a female patient, Mrs. XYZ, aged 42 years, residing in Agara, who's a homemaker by occupation and has completed her education till 7th standard. Her husband name is Mr. XYZ. He's aged 50 years and is a tailor by occupation. And they belong to lower middle socioeconomic status according to the modified Kupuswamy scale. And her obstetric score is para 2 living 2. Date of admission was 18 January 2020. Date of examination 22nd January 2020. She came with chief complaints of heavy menstrual flow since 3 months and pain abdomen during menstruation since 3 months. History of presenting it. The patient was apparently normal 3 months back and later developed complaints of prolonged and heavy menstrual bleeding, which was insidious in onset, progressive, lasting for 8 to 9 days in a 30-day regular cycle. She used 6 to 8 pads per day, and she also complains of passage of clots during menstruation. She complains of pain in the lower abdomen since 3 months during menstruation. The pain appears simultaneously with menstruation and gradually increases during the cycle and subsides after menstruation. The pain lasted for 8 to 9 days. It is of intermittent and dull aching type. It was non-radiating and pain was relieved on medication which was taken over the counter. There was no history of discharge PV, no history of intermenstrual bleeding, pain during intercourse, no history of fever, difficulty in micturition, no history of retention of urine or increased frequency of micturition. There's no history of difficulty in passing stools, no history of varicose veins, pedal edema, abdominal distension, no history of loss of appetite or unintentional weight loss, and there was no history of epistaxis or gum bleeding. Her menstrual history, her age of menarche was 14 years. Her present cycle is also a 30-day regular cycle with 8 to 9 days of flow, and she used 6 to 8 pads per day, and she complains of dysmenorrhea and passage of clots. Her past cycle was regular 30-day cycle where the flow was 4 to 5 days, and she used 2 to 3 pads per day. There's no history of dysmenorrhea or passage of clots in the past cycles. Obstetric history, her obstetric score is para 2 living 2, and years of marriage is 21 years, which is a non-consanguineous marriage. She had 2 children. The first child was a male child, a full-term vaginal delivery, which was delivered after 2 years of marriage. The second child was also a male child. No history of contraceptive use. Past history, she's not a known case of diabetes, hypertension, epilepsy, asthma, tuberculosis, or any thyroid disorders. She has no history of any coagulation disorders, no history of surgeries and blood transfusions in the past. Family history, there's no history of similar complaints in the family, and there's no history of any bleeding disorders in the family, no history of any malignancies in the family. Personal history, her diet is mixed, adequate in calories and nutrients. Her appetite is normal, sleep is undisturbed, bowel and bladder movements are normal, and she has no history of smoking and alcohol consumption. To summarize, a 42-year-old lady with an obstetric score of para 2 living 2 came with the chief complaints of prolonged heavy menstrual bleeding with passage of clots since 3 months and pain during menstruation since 3 months with no associated comorbidities, probably abnormal uterine bleeding.
Okay, Rekha, we'll start from the first slide now.
Okay.
Yeah, this part is correct. Next slide. Yeah, so the patient details were correct. Obstetric score, para 2 leaving 2, we don't mention here. Okay. And in gynec cases, we don't call it as obstetric score. It's a parity index. Okay. It is para 2 leaving 2 is our parity index. And that we usually mention just before starting with the chief complaints. Okay. Like we say, she is 42-year-old, para 2 leaving 2 has come with complaints of. Okay. Like after date of admission, after date of examination, then you mention the parity index, then you write the chief complaints. Okay. Yeah. So now let's go to the chief complaint. Okay, she has heavy menstrual bleeding and pain abdomen. Okay, next slide. Yeah. So now actually she has come with heavy menstrual bleeding. Okay, so nowadays we don't use the words like menorrhagia and all that is not used, right? We call it as heavy menstrual blood loss. It's a common terminology. We use it as HMB, heavy menstrual blood loss, right? Okay, now she is having complaints since 3 months. So what is the importance of number of pads and passage of clots?
Number of pads tells there's heavy bleeding, about how much bleeding she has, and
Okay.
passage of clots means it's there for a longer period of time, so there's the blood is getting clotted before it gets passed out. She has a prolonged bleeding.
Okay. See, number of pads, yes, one of the method to assess the menstrual bleeding is one method is subjective and objective methods. Both are there, right? So subjective methods of analyzing heavy menstrual blood loss is use of number of pads. How many pads she's been using, particularly when she's getting up in the night and she's changing the pads. Okay, so pad change in the night is particularly important for us. In the daytime, maybe it is basically as a subjective hygiene. Like some people might want to change the pads more frequently. Okay, so but if she's getting up in the night and changing the pads, that means she's definitely having heavy menstrual blood loss. Okay, and passage of clots, the reason is generally menstrual blood doesn't clot because of
Fibrinolysis.
yes, excess of
Displacement.
fibrinolysin. It is a normal physiological mechanism so that blood is easily passed through the cervical canal. So because of excessive fibrinolysin, normally the blood doesn't clot, menstrual blood doesn't clot. If there is a passage of clots, it means that coagulation pathway is taking over the fibrinolysin mechanism. So there is heavy menstrual blood loss. So passage of clots indicates that patient is having heavy menstrual blood loss. It is not that it is there for longer time. Okay. It is mainly because it says that indirectly it is a heavy menstrual blood loss. Okay. So what is the other method? One is number of pad usage, clots. Anything else will tell you that she is having heavy menstrual blood loss?
Pallor.
Okay. That is by clinical examination. By history,
Don't know.
it's always you have written that in the menstrual history. You should always compare her own cycle because each and every person menstrual cycle is different. She'll compare her current cycle with the previous cycle. Okay, so when you're presenting menstrual complaints in a gynae case, okay, past cycles and present cycle should come in the in the presenting illness, not in the menstrual history. You mentioned in the menstrual history, right? So you have to compare this cycle, the current cycles, with the previous cycles. If the patient does not have any any menstrual disturbances, just come with other gynae complaints, in that time you'll be writing in detail about menstrual cycles in the menstrual history. Here, because she has come with the menstrual complaints, you have to compare present cycle, past cycle here itself. Okay, it will come in the HOPI, history of present illness only. You have to write the present cycle and past cycles. Like she uses 6 to 8 pads, complaints of passage of clots and associated with pain. Past cycles, she was using 3 to 4 pads per day without any passage of clots, without any pain. Okay, so you are comparing both previous and current cycles in the HOPI itself when the woman presents with menstrual disturbances. Okay. Yeah, next slide. So she has actually pain during menstruation, so she has dysmenorrhea. So what type of dysmenorrhea it fits into?
Primary dysmenorrhea.
Sorry?
Primary dysmenorrhea.
Okay. Yeah. So one classification is calling it as primary and secondary. So the typical classification, depending upon the type of the pain and onset of pain, we classify it as
Primary, congestive and
spasmodic. Yeah,
spasmodic.
spasmodic, congestive, and membranous type are also called as atypical type of dysmenorrhea. Okay, so what type of dysmenorrhea is this one now?
This is a primary spasmodic type of.
This is a spasmodic dysmenorrhea. But
Yes.
typically what happens is spasmodic dysmenorrhea starts with the onset of menstruation. It peaks in the first 24 hours, but it never lasts for more than 48 hours. Okay, but here she is telling she has pain throughout the menstruation, right?
Yes, ma'am.
So it is little atypical. It is atypical type of dysmenorrhea here.
Okay.
Okay, though the starting of the pain and dull aching type actually fits into spasmodic type, here it is atypical because it is lasting. It usually spasmodic type never lasts for more than 48 hours. Here it is lasting for almost the whole of the menstrual cycle, almost for 9 days. Okay, whereas congestive type of dysmenorrhea, it starts prior to the onset of menstruation.
Yes.
Okay, why it starts prior to the onset of menstruation?
It's usually because of associated pelvic pathology, which is always present.
Yes, good. So it is actually basically because of the pelvic congestion, increased vascularity, increased prostaglandins, so increased pain before the onset of menstruation only it starts. Okay. Okay, next slide. Okay. So coming to the negative history. So negative history should be preferably in one order. Okay, like whatever is a common differential diagnosis, that should be ruled out first. Okay, so now here the actually before going to examination, here it is a case of abnormal uterine bleeding, right?
Yes.
Yeah. So what is the importance of your negative history? What all things you want to rule out?
Rule out various causes of abnormal uterine bleeding like endometriosis, adenomyosis,
Okay.
um, any ovarian mass,
Okay.
or um, any um, cervical causes of AUB, or any malignancy or hyperplasia.
Yes, good. So they all come under the causes etiology comes under what classification?
Palm coin
Yes.
classification.
So palm coin classification. So you're ruling out your negative history in this order only, organic and inorganic causes, right? First
Okay.
comes all the organic conditions, then all the non-organic, okay, non-structural causes, structural and non-structural causes you have to rule out.
Yes.
Okay. So the first thing what you want to rule out is actually
Uh,
any
for
polyps. Okay. So
polyps.
any abnormal discharge per vagina you have written. What is
Yes.
so in menstrual complaints, when the patient has come with menstrual complaints, you have to rule out other types of menstrual disturbances. So it is no history of any intermenstrual bleeding or post-coital bleeding. So you're ruling out the types of abnormalities in the menstruation here.
Yes.
Okay. So you have to mention no intermenstrual bleeding. You have written dyspareunia actually. You have to write actually no history of any post-coital bleeding.
Okay.
Okay. And why you have written fever and difficulty in maturation?
If there's any urinary infection in case of any.
Can UTI cause AUB?
No, ma'am, but if there is AUB, there can be for like any mass, like fibroids can cause.
No. Do fibroids cause UTI?
If it is a broad ligament fibroid, it can cause UTI.
No. Fibroids will never cause urinary tract infections. Okay. Very rarely they present large cervical fibroids present with retention of urine. In that case, it is a secondary cause of UTI. Okay. So there are large cervical fibroids. That's quite rare, right? So UTI is not a condition causing AUB here. Okay, so your negative history should be again no history of any mass per abdomen or mass per vagina. Maybe an examination you have found a mass, but she doesn't give you history of mass per abdomen, right?
Yes.
So here you should have been no history of mass per abdomen or mass per vagina, like fibroid polyp coming out.
Yes.
Okay, so no history of mass per abdomen, mass per vagina should be there. In AUB in reproductive age group, we ask history of fever and lower abdominal pain to rule out
If there's any fibroid in its
PID.
underbody.
To rule out PID, yeah, somebody answered. We ask history of fever and lower abdominal pain to rule out fever, to rule out PID basically. Okay, not UTI. UTI is not a cause for AUB. See, you're ruling out causes for AUB here. Secondary cause, if you're probably you're thinking of fibroid, then comes the secondary effects of fibroid, you're asking later. But first negative history, first differential diagnosis has to be ruled out with a negative history in the order of priority. Okay. So then comes, so history of retention of urine. Yeah, if you are suspecting fibroid, like if the patient had come with mass per abdomen, this is your first negative history. No history of retention of urine or no history of increased frequency, but not for AUB.
Yes,
Okay.
ma'am.
Yeah, you can write no bowel and bladder disturbances in the end of all the negative history to rule out any pressure symptoms. You can write in the end. Okay, no history of bowel and bladder disturbances should be written in the end. Okay, in the reproductive age group, if this woman were to be reproductive age group, then fever with lower abdominal pain will come here. Or otherwise, PID is the last differential diagnosis for you. So in the end, you write no history of any fever, abnormal discharge for vagina, or lower abdominal pain to rule out PID. Okay.
Okay,
Yeah.
ma'am.
So your first negative history will be no history of any intermenstrual bleeding, postcoital bleeding, or any type of other abnormalities in the menstruation. No history of any pain during intercourse. Yes, you can write. Okay. No history of any discharge per vagina. Okay. Next. Next slide. Yeah. This is basically you're asking for the pressure symptoms, right?
Yes, ma'am.
Yeah. See, all these, once you assume that it is fibroid, you can write this. Like if this patient were to come with complaints of mass per abdomen, this history is relevant. This negative history is relevant, but not for a case of a AUB. Okay. So for AUB, again, you have to ask for any other history of epistaxis and gum bleeding will come first. You have to rule out history of any bleeding tendencies. Okay. Any bleeding tendencies from any other sites that has to be asked for this patient. Okay. History of any thyroid abnormalities. Can thyroid abnormalities cause bleeding?
Yes, ma'am.
Yeah. Which one causes bleeding? Heavy menstrual bleeding?
Hypothyroidism.
Yeah. Hypothyroidism actually usually cause heavy menstrual bleeding, then followed by amenorrhea. Hyperthyroidism,
Oligomenorrhea.
oligoamenorrhea. Sometimes they can cause irregular acyclical bleeding, followed by amenorrhea again.
Okay.
Okay. So both types of thyroid abnormalities can be causative factor in AUB. Okay. So you have to write history of any symptomatology related to thyroid or history of any discharge from the breast. Why is that? Prolactinomas causing anovulation and then irregular acyclical bleeding, like that. Okay. So before this, again, when you're writing no intermenstrual bleeding, no postcoital bleeding, no history of any preceding amenorrhea. She never had any amenorrhea before these complaints. That should come first. One thing is why you have to ask history of preceding amenorrhea.
If she's already 42 years, she can be going towards menopause.
Okay. So you wanted to rule out postmenopausal bleeding.
Yes, ma'am.
Okay. That will be 1 year amenorrhea followed by irregular acyclical bleeding. Okay. So postmenopausal bleeding, here we are not suspecting postmenopausal bleeding. Any other reason why you have to ask amenorrhea?
If
Yeah.
there's any tuberculosis of the uterus and all, there'll be amenorrhea.
Okay. So tuberculosis causing amenorrhea, again, they never have heavy menstrual blood loss later. It will not happen. Okay. So someone answered pregnancy. Yes. You want to rule out pregnancy related complications. Okay. Like this patient, you have not mentioned she's tubectomized or not. She has not used contraception, right? She's para 2 living 2, but you have not mentioned whether she's tubectomized or not. But still, there are many women actually who have never been tubectomized. Even at the age of 42, they come with pregnancy complications.
Okay.
Okay. So it could be pregnancy later followed by bleeding, which could be like a abortion related complications, or it could be even gestational trophoblastic disease. Okay. Our important thing is most of the typical anovulatory bleeding, that is metropathia hemorrhagica, has got anovulation of, that is amenorrhea, then followed by heavy menstrual blood loss. Okay, so it is anovulatory type of AUB. Okay, so that should be written in no history of any preceding amenorrhea. That should be written. Okay, so history of bleeding tendencies you have written. Should we ask in this age group? She's 42 years, right? So
Yes,
history of bleeding tendencies, should we ask in the negative history in this age group?
yes, ma'am.
Why? Which causes you want to rule out?
Like any platelet disorders like immune thrombocytopenic purpura
Yes, good.
and, and vitamin C deficiencies.
Okay. Okay, so bleeding tendencies should be asked for AUB in all the age groups. For all the age groups, you have to ask bleeding tendencies. Okay, in younger age group, like in puberty, menorrhagia, and all that, the reason is actually congenital causes. It could be von Willebrand's disease, some congenital platelet diseases, other coagulation factor deficiencies like that. But in this age group, in the reproductive age group, actually, induce this immune purpuras or even ITPs are very common in the reproductive age group.
Hmm.
Okay, perimenopausal age is from 39 to 45 is perimenopausal, right?
Yes.
So in this age group also, you have to ask for history of bleeding tendencies. Here the causes are different. The causes here are actually acquired causes. The acquired causes could be, sometimes they will be presenting with the chronic myeloid leukemias, malignancies. They never have any other typical features except for only bleeding, gum bleeding and menstrual blood loss. Okay, or it could be even other acquired causes like drug induced, like patient is actually taking anticoagulation drugs for cardiac disease, or she is having some cerebrovascular accident, now she is actually on anticoagulants like warfarin. Okay, so if they are taking anticoagulants, they'll be having, if there is an excessive dose, they're present with heavy menstrual blood loss and also bleeding tendencies from other sides. Okay, or even other acquired causes could be like jaundice, like patient is having some chronic liver disease followed by coagulation factor deficiency, and then there is a bleeding. Our patient is having some acute viral fever, like dengue hemorrhagic fever, like that. They also have heavy menstrual blood loss with bleeding tendency from other sides. Okay, so history of bleeding from other sides is important for all the age groups. Only thing is causes keep changing. Okay, but if it's a younger age group, it will be congenital causes. But in the reproductive age group, the causes will change. And again, in the perimenopausal age group also, the causes keep changing. Okay, so it has to be asked in all the age groups. Okay, so you're ruling out polyps, you ruled out mass per abdomen, mass per vagina, and you have ruled out leiomyomas. Actually, there is no, it's difficult to rule out because fibroid is still a differential diagnosis. AOB, fibroid is still a differential diagnosis in this case, and even adenomyosis is still a differential diagnosis because she's presenting with,
There's no marked representation.
yeah,
It's
and she's
only
presenting with dysmenorrhea. She has severe dysmenorrhea, which goes in favor of adenomyosis still.
adenomas.
Yeah, right. And but she doesn't have pain in the other part of the menstruation.
Yes.
Okay, like other type of other part of the cycle, she doesn't have pain. Like in endometriosis, they usually have constant dull aching pain, irrespective of whether menstruation is there or not. What type of dysmenorrhea typically is described in endometriosis?
Secondary congestive dysmenorrhea.
Yeah, it is also called as triple dysmenorrhea. They have pain before the onset of menstruation, during the menstruation, and after the menstruation. So it is also called as triple dysmenorrhea. Here she doesn't have pain in the other part of the menstrual cycle, and age doesn't go in favor of endometriosis for her. Okay.
Yes.
So you are ruling out again. What is the other thing?
Even like little of malignancies, there's no
Malignancy. Yes,
weight loss,
malignancy is
abdominal
definitely a
distension.
possibility in this case. No history of any loss of appetite or loss of weight.
Yes.
That should come here. Yes, you have written that correct. So malignancies you are ruling out here. Okay. Then, and postcoital bleeding, again you are ruling out carcinoma cervix.
Carcinoma cervix.
Abnormal discharge could be because of the malignancy, carcinoma cervix.
Yes.
Okay, yeah. Then non-structural causes include one is coagulation factors. So coagulation factors you're ruling out by asking for the bleeding tendencies.
Yes.
Okay.
Oh,
Then
ovulatory dysfunction. Her cycle is
ovulatory
irregular, so
so anovulatory dysfunction is like history of preceding amenorrhea. Like that is goes in favor of anovulatory bleeding. Okay. So preceding amenorrhea and thyroid dysfunction. Thyroid dysfunction, if there is a thyroid abnormality in this patient, then it will be called as AUBO. Okay. E is actually endometrial. It is not endocrine, right? Yeah. So here ovulatory dysfunction is both even perimenopausal AUB and also thyroid dysfunction, prolactinoma, any galactorrhea associated with anovulation bleeding, they all come under ovulatory dysfunction. because they cause anovulation basically. Okay, so thyroid abnormalities also has to be ruled out. No history or suggestive of any thyroid abnormalities. Okay, that should come in your negative history. Okay, endometrial is difficult to rule out. It is basically a local cause. Okay, and iatrogenic, you have to ask no history of any chronic, any drug intake, like basically anticoagulants. You're ruling out anticoagulants, use of anticoagulants which has caused her AUB.
Okay.
Okay, and IUCD, anyway, it's unlikely. You have written later that she's not using any contraception. Okay, so here also you can mention that no history of any contraceptive use, because AUB, that is one of the differential diagnosis, right?
Yes.
Yeah. Iatrogenic could be both drugs and even IUCD. Okay, so all this differential diagnosis, the negative history related to this differential diagnosis should be in your history. Okay, so varicose veins, pedal edema, difficulty in passing stools, they don't go well with your case. For mass per abdomen, yes, all these were relevant. Okay, like in general, if you want to rule out any pelvic tumors associated with bowel and bladder disturbance, that history should come in the end. In the last, you can write, history of any bowel or bladder disturbances. So specifically, no need to write UTI or difficulty in passing stools.
Okay.
Okay, clear?
Yes, ma'am.
Yeah. Whenever you are presenting any history, the common differential diagnosis, negative history related to that common differential diagnosis should come in the first. Okay. Yeah. Next slide. Next slide.
Ma'am, 1 second, the slide.
Yeah. Okay.
Yes.
Yeah. So here you write generally in menstrual history, we write only past cycles. Okay.
Okay.
We don't write present cycles here if they have come with menstrual complaints. So you have to write these two, both these two in the HOPI. Okay. Here you mention, once you have described in the HOPI, here you write cycles as described earlier, write LMP. LMP has to be compulsorily written in menstrual history. Okay.
Ma'am, should we write her last normal period or any last
Okay.
even the
Last, when she had her last cycle, the current in the abnormal cycle, you can write that LMP first.
Okay.
Okay, that is important for us. So what is the importance of LMP? Why do we write LMP in gynae cases?
One reason is surgeries are usually planned post menstrual phase.
Okay. Yes, in the secretory phase, generally blood, actually the vascularity is higher, congestion is higher, so the blood loss might be higher. Okay, it's not important for hysterectomy, but it may be important when you're planning for a conservative surgery like myomectomy and all,
Myomectomy.
usually done in the post-menstrual phase. Yes. Then any other procedures you are planning, you are particular about LMP?
Or hysteroscopies and all are usually performed after the menses.
Yeah, they're all done in the post-menstrual. Okay. Endometrial biopsy, like in case of AUB. The case of AUB, if you are planning for an endometrial biopsy, either by a DNC or by a PIPLS, when you do it?
Immediately after the menses, ma'am, even before the ovulation.
Yeah, so it is in the premenstrual phase. It is in the secretory phase. The AUB, the reason is actually the progesterone deficiency, right? So you want to do the biopsy in the secretory phase to rule out any secretory type of endometrium is there or not. That will be checked in the histopathology. So that is premenstrual. Endometrial biopsy, when it is done for AUB, it is premenstrual. Okay, whereas surgeries are planned in the conservative surgeries are generally planned in the post-menstrual phase. Okay.
Yes.
Yeah, that is why you have to write the LMP. Okay. Yeah.
Okay.
Next slide. Okay. So any significance of obstetric history in this case, AUB?
In this case, no, ma'am. She's not nulliparous, so there's no risk factor.
Yes. Yeah. So parity is nulliparity is one of the risk factor for
Any estrogen dependent lesions like fibroids or endometriosis.
Yes.
endometrial hyperplasia.
Good.
And
Then
even the number of years she's exposed to estrogen
yeah.
after pregnancy also matters.
Yeah. Hyperestrogenic conditions, that is both fibroid, endometrial hyperplasia, malignancies, endometriosis, polycystic ovarian disease, PCO. All these are risk factors, right? Nulliparity is a risk factor for all these conditions. Multiparity is a risk factor for,
Adenomyosis.
yes, very good. Multiparity is a risk factor for adenomyosis. Okay. Here you have to mention whether she has undergone tubectomy or she has undergone sterilization or not. Okay, if she's not undergone sterilization, right? Not tubectomized or not undergone sterilization. That should be written here. Okay, yeah.
Okay.
Yes. So she has not used any contraceptive. Okay. So any contraceptive methods can cause AUB.
Yes,
What are
ma'am. Like
contraceptive methods can cause?
progesterone only pills can cause intermenstrual bleeding,
Yes.
and even the IUCDs can cause
Yes.
in,
Heavy menstrual blood loss.
yes.
IUCDs can cause heavy menstrual blood loss or even premenstrual or postmenstrual spotting they can cause. Okay. POP pills, progesterone only pills, and even injectable progesterone only injection, DMPA.
Yes,
Okay.
ma'am.
They also can cause irregular acyclical bleeding. Okay. And even actually, OCPs also conventional combined oral contraceptive pills, when they are taken missed pills, when they miss the pills for 2-3 days, they can have withdrawal bleeding in between the cycle.
Okay.
Okay, so even these are all the causes, even in the IUCDs also, definitely they can cause heavy menstrual blood loss. Yeah, somebody has asked what is the reason why adenomyosis is related to multiparity. Okay, so the exact etiology for adenomyosis is not known. One of the reason is after bearing children, like after pregnancy, during pregnancy itself, there is some trauma induced to the endometrium and endomyometrial junction. Okay, so because of that, there is an invagination of these endometrial glands into the myometrium, which can result in adenomyosis. Okay, so that is one of the factor why multiparity can cause adenomyosis. Okay, so whenever there is any trauma to the endometrium and endomyometrial junction, that can result in adenomyosis. So that is one of the theories. That is the reason actually adenomyosis is more common in the multiparous women, and it is usually seen around 40 years of age. In that age, by the time it is becomes more symptomatic. Okay, but there are many nulliparous women also can present with adenomyosis, but one of the etiological factors is multiparity. Okay, yeah, and yeah, what are the objective methods of assessing blood loss? That is one of the doubts. I mentioned about the subjective methods of blood loss, that is comparing with the previous cycles, estimation of use of pads, number of pad usage, particularly the nighttime pad usage, and even presence of clots. Okay, objective methods are actually you have even menstrual calendar. You ask the patient to maintain a proper menstrual calendar, like you ask her to mention what was the like how many days of cycle, how many days of flow she has got, and she also marks the superficial soakage, deep pad soakage, or even the clots, the weight of the clots also is mentioned. That is called as Higgam's method of assessing the menstrual blood loss. Okay, so other method is acid hematine method. Okay, so whatever number of pads she has used, so that blood you can estimate the amount of the blood lost in the pad. That is acid hematine method. And weighing of the pads, they do the weight of the pad before using and after use of the pad. They weigh the pad to estimate the blood loss. All these objective methods of assessment of blood loss are usually used only for research purpose, like when you're doing a study. Okay, like I want to know the effect of tranexamic acid on menstrual blood loss. I want to know the effect of the progesterone on heavy menstrual blood loss in this patient. So for research purposes, objective methods are used, like menstrual calendar, acid hematine method, weighing of the pads. Okay, so all these are used basically for research purpose only generally. Okay, so for history taking, for examination, for patient assessment, generally we use only subjective methods of assessment of blood loss. Okay, so how prolactinoma can cause AUB? It is mainly because of anovulation. Okay, so even in the hypothyroid and prolactinomas, there is impaired thyrotropin releasing hormone. Okay, there is excessive secretion of thyrotropin releasing hormone. Okay, that can cause excess prolactin and anovulation. Okay, they basically cause anovulation. Okay, we'll move to the next slide. Okay, so one more doubt is, can we rule out organic cause through symptoms? Okay, not most of the causes. Like mass, if a patient presents with mass per abdomen, you know that either it's a uterine tumor like fibroid or it could be a ovarian tumor. But if she doesn't present with mass per abdomen, it is difficult to rule out. You cannot say completely that there is no organic cause, only with the history. It is not possible. It's not you are not able to completely rule out, but you have to ask for any other associated symptoms. Like many patients don't say mass per abdomen, but when you ask a leading question, they say, yeah, vague mass is felt in the lower abdomen. Okay, so you cannot completely rule out organic causes only through symptoms. Okay, but negative history should be asked, leading questions should be asked associated to organic causes. Okay, like polyp can be ruled out with abnormal discharge per vagina and mass per vagina. If there is obvious mass per abdomen, it goes more in favor of a ovarian tumor or a fibroid. Okay, but all adenomyosis, if there is a presence of dysmenorrhea, or if there is a presence of continuous dull aching type of pain, endometriosis, all these things can be asked, okay, by leading questions, but they cannot be completely ruled out. Malignancy, hyperplasias also cannot be ruled out only with symptoms. It is not possible. Okay, but we have to ask any other associated symptoms like loss of appetite, loss of weight, all those things can be asked. Okay. So can mass per abdomen like ovarian tumors can cause AUB? Rekha,
Yes,
can they cause
yes,
AUB?
like certain tumors of ovary, like granulosa cell tumors, which produce more estrogen, they can also cause AUB.
Yes. So ovarian tumors can cause AUB, abnormal uterine bleeding. So that generally, actually, we expect that most of the time it is actually hormone secreting ovarian tumors like granulosa and theca cell tumors, but they are common in the extremes of age group. Either they're in the postmenopause or in the younger girls. Okay. But even epithelial ovarian tumors, large epithelial ovarian tumors like serous adenoma or mucinous adenoma can also cause AUB because of the surrounding normal ovarian tissue hypertrophy. Okay, so because of the normal ovarian tissue hypertrophy, there is excess estrogen secretion leading to actually AUB. Okay, so they are not typically hormone secreting ovarian tumors. They are actually even epithelial ovarian tumors, though typically they don't produce any hormones, but they can cause AUB because of the surrounding ovarian tissue hypertrophy. Okay, so that is why they are called as misfit tumor. They don't fit into the category of hormone secreting ovarian tumors, but they can cause AUB. That's why they are called as misfit tumors. They are actually epithelial ovarian tumors which can cause bleeding. Okay, yeah. Someone Harini has asked, can submucosal fibroid cause dysmenorrhea? Yes, fibroids can cause dysmenorrhea. Submucosal fibroid, even corneal fibroids can cause dysmenorrhea. They can cause both type of dysmenorrhea, both spasmodic and congestive type of dysmenorrhea can be associated with fibroid. Okay. Yeah. So past history, you have included all the factors. No history of any coagulation disorders, blood transfusion, yes. And you should also ask any history of chronic diseases like liver disease, all that, mainly to rule out coagulation factors. Okay. History of any chronic disease should be asked, and no history of any drug intake. Here, important is to ask for any drug history. No history of any chronic drug intake. Basically, to rule out anticoagulants here. Okay.
Okay.
Yeah. Next slide. Okay, yes, you know history of similar complaints in the family, no history of any bleeding disorders and malignancies. So, history of any malignancies, particularly genital malignancies, should be asked for all the cases. For all gynae cases, you have to ask history of malignancies in the family. Okay, yeah, this is correct. Next slide. Okay, here in nothing contributory here. Okay, yeah, next slide. You mentioned the summary. Okay, so this is not probably abnormal uterine bleeding. This is abnormal uterine bleeding, right? So here you need not mention probably. Okay, so she is a 42-year-old lady. Don't write obstetric score in non in gynae cases. right? 42-year-old lady, para 2 living 2, coming with heavy menstrual blood loss. Here you can use the word as heavy menstrual blood loss. This is your interpretation, right? Right, heavy menstrual blood loss associated with congestive type of dysmenorrhea since 3 months. You're writing everything in the patient's words here. Well, in summary, you can use your own words. Okay, right? 42-year-old, para 2 living 2 with heavy menstrual blood loss with congestive dysmenorrhea since 3 months, with no other associated comorbidities, with abnormal, with for that is abnormal uterine bleeding for evaluation.
Okay.
Okay. So it's not probably abnormal uterine bleeding. This is abnormal uterine bleeding for evaluation.
Okay.
Yeah. Okay. Next slide. So we'll go with the examination.
General physical examination. A 42-year-old female who is moderately built and well nourished. She is conscious, cooperative, and well oriented to time, place, and person. She weighs 61 kg and height is 156 centimeter. Her BMI is 25.1 kg per meter square. Her vitals, like her general physical examination, pallor absent, icterus, cyanosis, clubbing, edema absent. There's no lymphadenopathies. Thyroid appears central and normal. Breast appears normal on both the sides. Spine appears normal. Her vitals, patient is afebrile. Pulse is 78 per minute with regular rhythm. Good volume, normal character. Vessel wall is not palpable and all the peripheral pulses are felt. There were no delays present. Her blood pressure is 128 by 84 mm of Hg taken from the right arm sitting position, and her respiration rate is 16 cycles per minute. Per abdomen examination, on inspection, umbilicus was central and inverted. Corresponding quadrants moved equally with respiration. There were no scars, sinuses, dilated veins, or any visible pulsation seen over the abdomen. Hernial orifices were intact. Palpation, there was no local rise in the temperature, no tenderness, a firm mass with well-defined margins above an irregularly enlarged uterus with 16 weeks of gravid uterus size was palpated, and then the mass is mobile from side to side and also felt in the midline. On percussion, dull note is heard over the mass, no fluid trill elicited. Auscultation, normal bowel sounds were heard. Per-vaginal examination was not done. Systemic examination, her cardiovascular examination, S1, S2 heard, and there were no murmurs. Respiratory examination, normal vesicular breath sounds were heard. Central nervous system, no focal neurological deficit elicited. And provisional diagnosis, a 42-year-old presents with prolonged heavy menstrual bleeding and dysmenorrhea since 3 months. On examination, a firm, mobile, non-tender mass of 16 weeks gravid uterus size in the midline can be palpated, probably a case of abnormal uterine bleeding due to fibroid uterus.
Okay, so we'll start with a GP again, general physical examination. Okay, somebody has asked, what is how do you differentiate congestive and spasmodic type of dysmenorrhea? Okay, spasmodic is actually physiological type of dysmenorrhea. It is very common in girls in younger age groups generally, and it usually starts with the onset of menstruation. It just precedes or starts with the onset of menstruation. The peak of the pain is actually in the first 24 hours. It never lasts for more than 48 hours. It never lasts for more than 2 days. Okay, congestive type of dysmenorrhea starts prior to the onset of menstruation, almost 1 to 2 days prior to the onset of menstruation it starts. Okay, and it peaks during the phase of menstruation, and it usually comes down by 3 to 4 days. It never lasts throughout the cycle. Okay, so these are the two typical types. Okay, and spasm, both the types actually are relieved by analgesics. And congestive type are generally associated with pathological abnormalities with the pelvis. Okay, why discharge per vagina? Okay, so discharge per vagina, you are asking in the negative history. The negative history for abnormal discharge per vagina, we are asking to rule out polyp, infected fibroid polyps, or even for the PID. Patient is having abnormal white discharge, having fever and all, lower abdominal pain also, and yes, CA cervix, yes, good. Even to rule out CA cervix, malignancies. So we have to ask all the three has to be ruled out by asking discharge per vagina, abnormal discharge per vagina. Okay, yeah. So yes, coming to the slide, general physical examination. Yes, you are right. Next slide. your described head-to-toe examination. Here the importance should be given to the thyroid examination and breast examination to rule out prolactinomas and thyroid abnormalities, which I have written correct. Okay, next slide. And pallor is not there. So that is again one of the important factor. Most of the women usually, if they are coming with a pallor, it substantiates your diagnosis that a patient is actually having heavy menstrual bleeding. Okay, so but absence of a pallor doesn't rule out heavy menstrual bleeding. Okay, yeah, next. Yeah, so her systemic examination shows that she's actually stable patient. There is no tachycardia. She's not in failure. Like many patients with heavy menstrual bleeding, they also have systemic signs. Like in the HOPI, when you have mentioned history of present illness, there also again you have to ask history of any easy fatigability. Like patient is has got any features of anemia because of heavy menstrual blood loss. Okay, it says then you have to look for signs of if she has got easy fatigability and she's not able to do her household work properly now. Maybe she is going in for failure because of anemia. Okay, and persistent tachycardia. If the patient is having tachycardia, it goes in favor of your diagnosis that she is having impending failure. Okay, so that should be checked. Even when you're doing respiratory examination, also check for any basal crepitations to rule out features of failure. Particularly when the patient has come with easy fatigability or when the patient is having pallor. Okay, so look for the systemic signs of failure. Increased JVP, okay, basal crepitations in the respiratory examination, pedal edema. Okay, all these things has to be looked for. Okay, yeah. Next slide. Yeah. So inspection, umbilicuses. Okay. So first thing what you write is size and shape of the abdomen. The first thing what you comment is actually abdomen is normal in shape. Or is there any distension in the lower abdomen? So here, because she has come with mass per abdomen, but mass is actually not big. It is very 16 weeks only. So maybe you may not see any distension of abdomen, obviously on inspection. Okay. So you can write abdomen is normal in size and shape. Okay. And no distension. Then you write the umbilicus, scars, sinuses, all this can be commented. Yeah, all these are normal. But first thing is comment on the size and shape of the abdomen. Okay. Next slide. Yeah. So coming to the mass. So when you're describing mass per abdomen, first thing what you have to write is where is it located? I mean, where exactly is the situation or where exactly it is located, the mass per abdomen. So first thing you write is there is a mass in the which quadrants of abdomen. Okay, mass in the you have to write what are the quadrants of abdomen?
Hypogastric and
Right and left iliac fossa, hypogastrium. Then
uh,
right and left lumbar umbilical
and
area, then epigastrium, right and left hypochondriac. Okay, so you have to write where exactly is the mass. Okay, so mass is situated in the hypochondrium, extending into right iliac fossa, left iliac fossa, or extending into umbilical area. This should be written.
yes.
Okay, so you have to first thing is where exactly is located. Where exactly is the location has to be written first. Okay, so after the location, then you mention the consistency. Okay, consistency, borders, then comes your mobility.
Yes.
And okay, so borders and surface has to be mentioned first. Okay, so then you have mentioned consistency, yes. So it is located in the hypogastrium, maybe extending into umbilical, I think 16 weeks, right?
Yes.
Yeah, you can compare it to gravid uterus if it is a central mass. Lateral masses cannot be compared to a gravid uterus. If it's a central mass, I assume that it is a central mass, so it can be compared with a gravid uterus. Okay, so a mass occupying in the hypogastrium extending into umbilical area of 16 weeks, corresponding to 16 weeks of gravid uterus size. It is firm in consistency with well-defined borders. Can you make out lower border or not?
No, ma'am.
So that should be written. Firm in consistency with well-defined borders, except the lower border is not felt. Okay, surface is smooth, or here your written surface is actually irregular.
Yes,
Right, it's irregularly enlarged uterus. So here it is actually surface is irregular. So it is not a uniform surface. Okay, then comes the mobility. Okay, so mobility is present from side to side. Okay, yeah, and it is felt in the mobility is present from side to side and it is felt in the midline. You mean to say the mass is felt in the midline?
Yes, ma'am.
Okay. Yeah. So generally, if the lower border is not made out, we assume that it is a
A fundal.
no. Why lower borders are not made out? Why do you think in this case lower border is not made out?
If it's a fundal fibroid, we
Huh.
cannot make out the lower margin.
Yeah. So lower border is not made out means that they're pelvic masses.
Oh,
So though the lower part is still in the pelvis, that's why you're not able to feel it.
yes.
Okay. So lower border is not made out means that the masses are coming from the pelvis. If there are abdominal masses arising from any intestine or anything, most of the time you'll be able to make out a lower border. All the borders will be very well made out. Okay, so if the lower border is not made out, it says that the mass is coming from the pelvis. Okay, there are exceptions, like if there is a large pedunculated fibroid or there is a ovarian mass with a longer pedicle, it can be lifted out of the pelvis. That time you can make out the lower border also, but most of the time, 90% of the time, masses arising from the pelvis, you cannot make out the lower border. Okay, but there are exceptions, like in case of pedunculated fibroid or pedunculated, or there is a long pedicle ovarian tumor, or there is a large ovarian tumor which is completely lifted out of the pelvis now. In those cases, you can make out lower border. Okay, so lower border doesn't made out means that it is the mass is coming from the pelvis. Okay, so what is the importance of consistency here?
Yeah, if it is cystic if it is cystic, like nodular, then it can indicate some cystic lesions of ovary. Uh,
Yes. So
if it
whenever
is
patient comes with a mass
uniformly
per abdomen,
enlarged, it can be
yeah,
adenomyosis.
yes,
And if it is irregularly enlarged, it can also be multiple fibroids.
okay, yes. So how do you differentiate uterine tumor, that is fibroid, from the ovarian tumor?
An ovarian tumor is usually nodular and it can be bilateral, and it's usually adnexal masses. It's not exactly in the midline,
Okay.
whereas uterine masses are in the midline, and even the growth of the mass is very fast in case of ovarian masses, but uterine masses usually grow slower.
Yes, insidious in onset and rapid onset. Yes.
Mm.
Okay. So it depends upon whether you're doing a abdominal examination or a pelvic examination. Okay. So for us, the important mass per abdomen is actually two cases. What we have to differentiate is only from ovarian tumor and or from a fibroid. So these are the two things which has to be differentiated from your examination. It could be even tubovarian masses also, PAD, tubovarian masses also. Okay. But generally we have to rule out fibroid from a ovarian tumor, right? So fibroids are usually midline masses, whereas ovarian tumors, they're actually lateral masses most of the time, but large tumors can occupy whole of the abdomen. You cannot make out. But generally, smaller ovarian tumors are actually lateralized. They're more towards right iliac fossa, left iliac fossa, towards one side. Okay, whereas uterine masses are generally in the midline. Okay, and coming to the consistency, fibroid are generally firm to hard. They're firm to hard in consistency. Okay, ovarian tumors are generally either cystic, completely cystic, or they can be variable in consistency. Like in malignant ovarian tumors, some areas you feel cystic, some areas you feel that it is actually solid. Okay, so that is called as variable consistency. Okay, and borders and surfaces, most of the time it can be both. It is confusing for both ovarian tumors and fibroid. Fibroids are most of the time they are actually smooth surface, but there can be multiple irregular surface can be there if there is a multiple fibroids, right? Ovarian tumors are also most of the time surface is smooth, but if it's a malignant ovarian tumor, multiloculation can be made out, irregular enlargement can be made out even with the ovarian tumors. Okay, so so these are the two important things. And you mentioned bilaterality. Yes, bilaterality goes in favor of ovarian tumors, but it is difficult to make out with the abdominal examination. Okay, and presence of ascites goes in favor of ovarian tumors, malignant ovarian tumors. Okay, next coming to pelvic examination. So in bimanual pelvic examination, you can make out,
Groove sign.
yes, groove sign. So the mass is separately felt from the uterus. there is a gap between the mass and the uterus, that is a groove. If there is a groove sign is felt, then definitely the mass is going to be a ovarian tumor most of the time. Okay, so that is groove sign. And other thing is
It will move along, the mass will move along. When you move the cervix or the mass, they move along together in case of a uterine mass. In an ovarian mass, the cervix does not move along with it.
yes. If you move the mass, you have to move the mass. Abdomen mass has to be moved to see whether the movements are transmitted to the cervix. Okay, so if the movements are transmitted to the cervix, then it is most likely a uterine mass. If the movements are not transmitted to the cervix, then it is most likely a adnexal mass. Okay, so that is groove sign and transmission of movements to the cervix. So these two can be made out with a bibanal pelvic examination. Okay, so but exceptions are there for all the conditions. Okay, there's a large broad ligament fibroid. You can make out groove between the uterus and the mass. It's a broad ligament fibroid. You can make out, though it is a uterine mass. Okay, there's a malignant ovarian tumor with extending into uterus. There is adhesion, it's adherent to the uterus. You can make out that movements are transmitted to the cervix even in case of a malignant ovarian tumor, but that are actually advanced features. Okay, but these are actually classical signs. Okay, even consistency, as I mentioned, like firm consistency, firm to hard consistency goes in favor of fibroid, but there is a degenerating fibroid, then the consistency can be even soft also.
Yes.
Okay, so cystic degenerations, hyaline degenerations can make, or red degeneration can make the fibroid softer. Okay, but firm to hard mass generally goes in favor of a fibroid, whereas a cystic mass or a variable consistency goes in favor of a ovarian tumor. But exceptions are there for all the conditions. Okay, yeah. Then coming to the mobility, you mentioned the mass is mobile from side to side. What is the importance of that?
It means it's usually it can indicate it's a submucous fibroid or it's.
Okay, so most of the pelvic masses are mobile from side to side. Okay, pelvic masses cannot be moved generally in the vertical direction. Okay, so mobility is present from side to side generally indicate that they are actually pelvic masses. Okay, exception again, as I mentioned, if there is a large pedicle is there for a ovarian tumor or large pedunculated subserosal fibroid, you can move side to side and even vertically also. Okay, but generally if the movement is only in the side to side but not in the vertical direction, it says that it is actually a pelvic mass. Okay, one of the differentiating factors for a ovarian tumor from a mesenteric cyst is vertical mobility. Okay, mesenteric cyst is mobile in the perpendicular to the axis of attachment. Generally, ovarian tumors are mobile, not mobile in the vertical direction. Okay, so mobility is important when you're differentiating an ovarian tumor from a abdominal mass like a mesenteric cyst. Okay, but pelvic masses generally we mentioned that mobility is present in the side to side but not in the vertical direction. Okay, yes. Next slide. Any doubt? You want me to repeat anything?
No, ma'am.
You understood?
Yes, ma'am.
Yeah, so when you're describing the mass, you have to mention the location, where what are the quadrants it is there. So location is you have to describe in terms of quadrants only. You have to describe in the quadrants. Then you after describing the location, you have to write about the consistency, borders, surface. Then you write the mobility. Okay. Yeah. And someone has asked, mobility in the ovarian tumor and fibroid are same. Yes, all the pelvic masses move in the side to side direction. Okay, very large pedunculated fibroid, very large pedunculated ovarian tumor can have vertical mobility, which is rare. Okay, they're quite rare. Generally, abdominal masses have movement in all the directions. Okay, other abdominal intestinal masses or mesenteric cyst have movements even in the vertical direction. But otherwise, pelvic masses generally are mobile in the side to side. Okay. Yeah. Next comes percussion. So, what is the importance of percussion here?
One is to assess if there's ascites. So there's no fluid present because
Yes.
ascites is usually seen with ovarian masses.
Yes. Good.
And dull note indicates that it's not a cystic lesion and it's a firm mass.
Okay. Okay. So, importance of percussion basically is for actually ascites and a large ovarian cyst. There is a thin-walled large ovarian cyst, like a serous cyst. Or you want to differentiate that from a ascites. In that case, percussion is important for us. Okay, for gynecologist, for us, importance is actually to differentiate a large ovarian tumor, thin-walled ovarian tumor from a ascites, encysted ascites collection. Okay, so in that case, how is it important? Percussion, what is the features of percussion in ovarian tumor versus ascites?
In the not sure.
Okay, so in ascites, what happens is actually bowel actually float in the fluid. In ascites, bowel float in the fluid. So you will have central resonance, whereas dull note in the flanks. Okay, in ovarian tumor, large ovarian tumor displaces the bowel to the flanks. So in the center, it will be dullness, whereas in the flanks, it will be resonant because bowel are displaced to the flanks. Okay, so percussion is important. One thing is, as you mentioned, to rule out ascites, to presence any, I mean, to note any presence of fluid along with the ovarian tumor. Okay, so other thing is to differentiate ascites from a ovarian tumor. Okay, how ovarian cyst gives rise to ascites? So in malignant ovarian tumors, basically it is actually the peritoneal irritation leading on to excessive collection by the peritoneal mesothelial cells. Okay, yeah. So auscultation, yes, and you don't do pelvic examination in any gynae cases, yes, but don't write PV in gynae cases. It is always bimanual pelvic examination. Okay, PV is done only for obstetric cases. Vaginal examination is done only for obstetric cases. In gynae cases, you don't call it as PV. I know routinely we write it as PV, but it is never called pelvic vaginal examination. It is called bimanual pelvic examination. Okay, so you are using both the hands, one abdominal hand and one vaginal hand, and you are trying to make out the uterine size in that. Okay, so don't write PV examination, write it as BPV, bimanual pelvic examination. Not done. Yeah, generally we don't, I mean, we don't expect undergraduates to do bimanual pelvic examination. Okay, yeah, next slide. Systemic examination, everything is normal. In all the, I mean, when you're taking medicine and surgery cases, so generally you are taught that whichever system is abnormal, that should be examined first, then followed by the other systems, right?
Yes,
That is why you have written systemic examination in the end. Okay. Only in OBG, we write systemic examination first, then followed by abdominal examination. Okay. Both obs and gynae. When you're writing history, I mean, both for obstetric history and for gynec history, gynec cases, first we write the systemic examination. As soon as you finish general physical examination, head to toe examination, vitals, after vitals, you write systemic examination, cardiovascular, respiratory system, CNS, then you write the abdominal examination. Okay.
okay.
Yeah. That is standard almost followed in all the medical colleges as far as I know in OBG. Okay. Uh, yeah, someone has asked, pouch of Douglas is need to see, ma'am, fluid in the endometriosis. I didn't understand this question. Pouch of Douglas. Okay. Endometriosis doesn't lead to fluid collection. What we see is actually presence of chocolate cyst, or there is, when you're doing a bimanual pelvic examination, you can make out that uterosacrals are nodular. In the POD, you feel that there is a nodularity in the POD, pouch of Douglas, but there is no presence of fluid. Okay, you can make out adnexal cystic masses. If you are doing a bimanual pelvic examination, could suggest chocolate ovarian cyst. Okay, it's very small, scanty fluid in the POD. In endometriosis, generally actually doesn't lead to ascites. Okay, and what is the importance of percussion? Yeah, percussion is, one thing is to rule out free fluid, presence of ascites associated with malignant ovarian tumors, or it is actually one of the important differentiating factor for percussion is used is actually to differentiate thin-walled ovarian cyst versus ascites. In ascites, in fluid collection in ascites, bowel actually float in the center. So in the center, because of the bowel, there is resonant note. Okay, because of the fluid in the flanks, it is dull in the flanks. Okay, whereas in ovarian tumor, because ovarian tumor extends anteriorly, it displaces the bowel to the flanks. Ovarian tumor displaces the bowel to the flank, whereas in ascites, bowel float in the fluid, so it is in the center. Okay, I hope you understood that. It is given in your textbook. Datta Gynec, I think Datta it's given. Datta Gynec textbook it's given. Okay. So if you are doing for a ovarian tumor, there is a resonant note of the bowel is felt only in the flanks. If it is ascites, actually flanks are dull. Okay. Yeah. Next slide. Yeah. Diagnosis. Okay. Diagnosis. You have written a summary here. Diagnosis is in diagnosis. You don't write complaints like prolonged heavy menstrual bleeding, uh, and firm mass is felt. All this comes under case summary.
Okay.
Okay, so case summary, you can mention that 42-year-old lady presenting with heavy menstrual blood loss and congestive type of dysmenorrhea since 3 months. Examination revealed 16 weeks gravid uterus size, mass, firm in consistency. These things come in the case summary. Okay, diagnosis, you don't use any of the patient words.
Okay.
Okay, so here the diagnosis is actually, so yeah, you
Fibroid,
diagnosis, yeah.
fibroid uterus.
So 40 diagnosis will be, you have to mention the age, parity, and the diagnosis, and any associated like diabetes, hypertension, any associated factors are there that should come in your diagnosis. So here your diagnosis will be 42-year para 2 living 2 with abnormal uterine bleeding, probably leiomyoma.
Okay.
Okay, so here it is 42-year-old para 2 living 2 with AUB. Okay, probably leiomyoma. Here it is definitely all the features are, most of the time actually features are going in favor of leiomyoma. Can it be adenomyosis?
No, ma'am. Adenomyosis will usually cause uniform enlargement, and it's also adenomyosis will not be 16-week size. It will usually be 10 to
It's
12
very,
weeks.
very rare to find adenomyosis more than 12 weeks size.
Yes.
Okay, generally adenomyosis is never present as mass per abdomen. They never present as mass per abdomen. The maximum size generally is actually around 12 weeks. Okay, so what are the factors in your case which goes in favor of leiomyoma?
One is the age of the patient, which is 42 years,
Yes,
because leiomyoma is common between 35 to 45 years,
yes.
uh, and she has a heavy menstrual bleeding, and there's no history suggestive of endometriosis or adenomyosis like intermenstrual bleeding or dyspareunia. And
Okay.
there
No
is
need
a
to mention the negative history. Tell me only the
okay,
positive findings. She's come
okay.
with AUB.
And
Definitely it is,
examination,
yeah, definitely
there
it is
is,
leiomyoma. AUBs generally are very common with the leiomyoma, right?
yes.
Yeah. Huh.
And on examination, there is a mass per abdomen which is irregularly enlarged, a firm mass which is 16 weeks gravid uterus size.
Okay.
So, which is suggestive of leiomyoma.
Yes. Yes. So all the findings in your case actually are in favor of leiomyoma. From the age, from her complaints, and even the examination findings, there is no doubt that it's going to be a leiomyoma. Okay. There can be coexisting adenomyosis because adenomyosis is again hyperestrogenic condition. Myoma, leiomyoma, and adenomyosis can be coexistent. That is also possibility. And again, one more coexisting condition in, okay, we'll discuss the management now. Okay, yes, your diagnosis is correct. Okay, this is 99%, it's going to be a leiomyoma. Okay, so how will we manage this case?
First,
Just 1 minute. Somebody has asked one doubt. Should we limit percussion to the mass or the whole abdomen? Whole abdomen. You have to do the percussion of whole abdomen to rule out free fluid. Okay, you're checking for the shifting dullness, right? So it is not just the mass. You're not doing percussion only for the mass. Okay. You have to do the whole abdomen. You have to check for the shifting dullness also to rule out presence of free fluid associated with ovarian tumor. So percussion is not just limited to the mass, it is to the whole of the abdomen. Okay. Yeah. So coming to the management, how will we manage this case?
first investigations, ma'am. The normal blood examination of the blood count, platelet count has to be done, and then ultrasound is done. Ultrasound helps in diagnosing a leiomyoma, and
Okay.
if it is a submucous fibroid and all, which it can be easily picked up by saline infusion sonography. and otherwise hysteroscopy can be done again for a submucous fibroid. And because she's also to differentiate if to rule out adenomyosis, MRI can be done. And for because she's 42 years old, we have to even rule out any endometrial hyperplasia, and also endometrial sampling should be done.
Yes, good.
And if and and laparoscopy can be done to uh, check for any subserous fibroids or any.
No, that can be done with ultrasound. No, why you want to do laparoscopy for investigations?
And hysterosalpingogram can be done because a fibroid will show a filling defect on hysterosalpingogram. And color Doppler can be done to check the vascularity of the mass.
Okay. Okay. So we'll go with the individual investigations. You're right. Most of the investigations you have covered. Good. Okay. But laparoscopy is never the investigation. Okay. Never include laparoscopy in the investigations. Okay. So most of the investigations you have covered. So complete blood count, definitely yes. And you have to rule out, like I mentioned, even for the differential diagnosis, even for the investigations, you have to remember your etiological factors. Right? You remember the palm coin classification here again.
Yes,
You have to rule out all the factors in the palm coin here.
yes.
Okay. So you are ruling out coagulation factors. You are ruling out thyroid abnormalities
Thyroid.
also. Yes. Yes. So these two should never be forgotten. Okay. So coming to your complete blood count, you want to rule out one thing is whether she's anemic or
Anemic.
not, and
Yes.
also rule out any platelet disorders.
Yes.
Any platelet dysfunction is there, that also has to be ruled out. Coagulation test has to be done for her. Okay. PT, APTT has to be done for her. Okay. Then comes your ultrasound. Then comes your thyroid profile, then your ultrasound. So thyroid profile is actually we do thyroid profile for all the patients coming with abnormal uterine bleeding. Okay, AUB can itself will be one of the symptoms about for thyroid, both hypo and hyperthyroid. Okay, so for all the AUB cases, you are going to do a thyroid profile. Okay, or at least simple serum TSH has to be done. If not T3, T4, and TSH, at least TSH has to be done for all the cases with AUB. Okay, then comes okay, and serum prolactin is not done unless she has actually galactoria. She doesn't have any galactoria, her breast examination is normal, so serum prolactin is not required for her. Okay, then comes ultrasound. Ultrasound is the most important investigation for you to confirm your diagnosis. Okay, so which ultrasound you want to do, transabdominal or transvaginal?
Transvaginal.
Okay, for all the cases, for all the pelvis, for all the gynae cases, both scans will be done.
Okay.
Both transabdominal and transvaginal scan. Okay, we generally ask that question, but you have to answer both will be done. Okay. Abdominal scan will give you a panoramic view. It's a broad view. Okay. Like if I want to know that it's a 16 weeks fibroid with hydronephrosis is there or not. So I want to rule out any other associated pathology. So in that case, I'll need abdominal scan, right?
Yes.
I just don't need confirm only the uterine size. I need to know the even the other abdominal pathology or even the pressure symptoms I should know, right? So in this case, abdominal scan is a compulsory thing, and most of the masses when they're felt for abdomen, trans-abdominal scan is more than adequate. Okay, so in this case, trans-abdominal scan is more than adequate in this case. Okay, but if there is a ovarian tumor, okay, or even in case of fibroid, it's a multiple fibroid uterus, and you want to give a conservative management. You want to know submucosal fibroids are there or not. In those cases, and even to measure the endometrial thickness properly, transvaginal scan is better. Okay, so for all the cases, you have to do both transabdominal and transvaginal scan. Okay, abdominal scan will give you a panoramic view, it will give you a broad view. Okay, but you want to know what exactly is the nature of the mass, whether it is a like it's a ovarian tumor, whether is there any thickness of the septation, whether it's a multi-septate. If there is a septation, what is the thickness of the septation? Okay, and what is the content? Is there any echogenic calcification inside the ovarian tumor? Okay, or in case of fibroid, is there any submucosal fibroids, small submucosal fibroids, which may be missed with the transabdominal scan, can be made out with the transvaginal scan. Okay, so but transvaginal scan for fibroid uterus is required mainly to rule out submucosal fibroids. Small fibroid polyps can be ruled out. Okay, otherwise TVS is not required in cases of 16 weeks of fibroid uterus. Okay. You want to rule out fibroid from an adenomyoma, ultrasound is definitely beneficial. And as you mentioned, MRI has got better sensitivity compared to ultrasound for adenomyosis, for adenomyoma. Okay, even with a good ultrasound, we can make out adenomyosis, but better clarity will be made out with the MRI to differentiate fibroid from a leiomyoma from a adenomyoma. Okay, so ultrasound here, actually the important transabdominal scan is important for us. Okay, one thing is to know the what is the type of the tumor, whether it is arising from the uterus or from the ovarian tumor. Okay, and what exactly is the nature of the tumor can be made out. Okay, and anything else you can make out in the ultrasound here?
Any degenerative changes for the
Yes,
of the fibroid?
calcifications can be made out. Any calcifications are there, and even cystic degenerations can be made out. Okay, it's difficult to make out fibroid and the hyaline degenerations with the ultrasound. That is not possible. Okay, then
And
anything else you can make out?
the
Anything else you want to know in the
vascularity of the
ultrasound?
fibroid.
Yes, you said about the Doppler. So anything, then you have to know even the endometrial thickness.
Yes, ma'am.
Okay, it could be fibroid, it could be a long-standing fibroid, but maybe now she's having a endometrial hyperplasia and malignancy. Maybe she's having endometrial cancer.
Yes,
Okay, like fibroids can be coexistent with the endometrial cancer. Okay,
yes,
now her symptoms could be because of the underlying endometrial CA. It may not be because of the fibroid, right?
yes.
So 3% of the times actually they can be coexistent. So that's why you mentioned about endometrial biopsy. It always, though there is an obvious cause that it is a fibroid, endometrial malignancy or hyperplasia has to be ruled out in this age group. Okay, so you have to know the endometrial thickness in the ultrasound. That is again important. Okay, so you can differentiate uh, fibroid from adenomyosis and even from a ovarian tumor. Okay, so these three things can be differentiated. Along with that, you will also know endometrial thickness in ultrasound. Okay, and presence of any other pressure symptoms like hydroerythronephrosis, presence of ascites. They can be additional features if they're present in the ultrasound. Okay, yeah. And fibroid mapping, like exact location of the fibroid, number of the fibroid in relation to the vicinity of the ureter, they also can be made out, but that is important when you're planning for a conservative management like myomectomy. That is called as fibroid mapping. Like what is the distance from the endometrial cavity? What is the distance of the fibroid from the endometrial cavity? How many number are there? Whether it is in the anterior wall, lateral wall, posterior wall, whether it is cervical fibroid, okay, or is there any presence of degenerative changes in the fibroid? All those things are important mainly for the management when you're planning for a conservative management. Not when you're planning a hysterectomy, you need not do exact fibroid mapping is actually not required. Rarely you may have to, fibroid mapping is required only for a broad ligament or a large cervical fibroid. Okay, otherwise fibroid mapping is generally not required. In this case, it may not be required. Okay, yeah. So Doppler, what is the importance of Doppler in this case? You said blood flow studies, right?
Yes, the vascularity of the.
So how is it important? Is it
If
what is the
it's
important?
highly vascular, you can use pre-medication, pre-surgically you can use drugs like they use drugs to shrink the size of the fibroid or vascularity of the fibroid.
Okay, no, I'm asking for investigation. How is it Doppler helpful to make out your diagnosis? Okay, so generally fibroids have got, actually they have got a capsule and the blood vessels run in the surface capsule. Okay, so whenever you switch on the Doppler on a fibroid, you can make out that the vascularity is surrounding the fibroid. Okay, whereas in adenomyosis, the vascularity is diffuse. It is present even throughout the tumor.
Yes.
Okay, so that is how you differentiate, one of the differentiating factors. There are many differentiating factors for adenomyosis and fibroid and ultrasound. With Doppler, actually what happens is in fibroid, there is a peripheral vascularity, whereas in adenomyosis, it is a diffuse vascularity. The blood vessels will be present throughout the tumor. Okay, so that is again one of the differentiating factor. And Doppler is more important for a ovarian tumor. Like if you want to differentiate benign and malignant ovarian tumor, it has got importance. Actually. Okay. Yeah. So that is about ultrasound. Okay. So next investigation you mentioned actually is endometrial biopsy.
Yes,
Before going to endometrial biopsy, remember even pap smear.
okay.
Okay. So though cervix looks normal, it could be even carcinoma early. It could be early invasive carcinomas. Okay. So remember pap smear, cervical cytology has to be done. Then comes your endometrial biopsy. Okay, so sometimes they'll ask you how to do cervical cytology, and they ask you how to do endometrial biopsy. Okay, so what are the methods of doing endometrial biopsy?
The office method,
Good.
and they use a pipple smear uh, to extract they do endometrial sampling, or it can also be done by hysteroscopy and biopsy.
Hmm.
And
Yes. Yeah, good. Okay, so office method of taking endometrial biopsy is actually using a pipelles cannula. Okay, pipelles cannula. So it is a small plastic cannula where you are going to aspirate the endometrium. Okay, and it is relatively painless procedure. It doesn't need any dilatation, and it is a plastic cannula. It doesn't need, I mean, it doesn't cause any curettage pain like that. Okay, so it is a simple method which can be done in the OPD basis itself. Okay, so Pipel's endometrial biopsy is actually become a routine procedure for all the AUB cases. For all abnormal uterine bleeding, you can do, I mean, perimenopausal AUB. For all the perimenopausal abnormal uterine bleeding, the one of the first method will be, after taking pap smear, will be next will be endometrial biopsy using a Pipel's cannula. Okay, so other methods of taking endometrial biopsy is standard DNC, dilatation and curettage. Okay, like it's a minority procedure. You ask the patient to come to minority, you do a dilatation, and then followed by curettage of the endometrial tissue of all the walls. Okay, but that is slightly painful. Patient needs some analgesics because you are doing the dilatation and curettage. Okay, so patient does definitely need some analgesics. It is more painful procedure compared to a office Pipel's endometrial biopsy. Okay, so that is DNC, and then comes actually hysteroscopic guided. Okay, so gold standard method of taking endometrial biopsy is hysteroscopic guided. So in hysteroscopy, you are putting a telescope into the uterine cavity through cervix. You are visualizing the uterine cavity, and you are seeing, is there any local polyps, small polyps which could have been missed with the ultrasound. Okay, 5 millimeters and smaller polyps can be missed with the ultrasound. Okay, that can be visualized with the hysteroscope, and also you can make out local any focal hyperplasias are there or not. Is there any focal thickening of the endometrium? From there exactly you can take a endometrial biopsy. Okay, that is why it is the gold standard method of taking a endometrial biopsy. Okay, some cases of endometrial cancer may be missed with the pipelles or even with the DNC, but usually hysteroscopy will not miss the abnormal focal sites. Okay, that's why it is mentioned as the gold standard method of taking endometrial biopsy. Okay, so these are the investigations. Okay, and other investigations are not needed in your case. MRI is required, like if you are actually, what is the role of MRI in investigation for AUD?
to rule out adenomyosis.
Yes, good. Then,
And
yeah, and I mentioned already, only when you're mapping the fibroid for a conservative surgery, like if you're planning for a myomectomy,
yes,
in those cases you can do a MRI. Okay, or when you're not sure that it is a fibroid or whether it is adenomyosis. Okay, in that case you can do a MRI, but here in this case even that is not required. In your case MRI is not required because neither you are planning for a conservative surgery nor you want to rule out from a adenomyosis.
yes.
Okay, so here actually MRI is not required, but MRI can be used if you want to really rule out between a adenomyosis or for a leiomyoma, and that too when you're planning for a conservative surgery. Even in that case,
Hmm.
so only when you're planning for a conservative surgery, MRI is very helpful in mapping the fibroid, in differentiating from a adenomyoma.
Okay.
In this case, if this were to be adenomyosis, so again management will be the same, treatment will be the same for her. Okay, so it doesn't matter. Hmm?
Yes,
Or
ma'am.
when you're planning for a other conservative management for fibroid like uterine artery embolization,
Hmm.
in those cases you can follow up with the MRI. Okay, to see for the any decrease in the size of the fibroid, that can be made out with the MRI. Otherwise MRI is of not much use in this case. Okay, and HSG is not useful. We don't do HSG for AUB cases. We never do hysterosalpingogram. Okay, very rarely, like when the endometrial thickness is 20 millimeters and higher, you are suspecting that there is a submucosal polyp. There's a small submucosal polyp which is not made out with the routine scan, routine two-dimensional ultrasound. You can do saline infusion sonogram. You can instill saline into the into the uterine cavity so that the polyp stands out better. Okay, so otherwise it is not done. Saline infusion sonogram is also not done. Okay, but other optional investigation in your case can be saline infusion sonogram to rule out submucous fibroid polyps. Okay. In your case, actually, you don't need HSG. HSG is never done for any AUB. We don't do HSG. Okay. Only if the patient is coming with persistent amenorrhea, secondary amenorrhea, no, you want to rule out genital tuberculosis, intrauterine syncytia formation in those cases. Okay, otherwise HSG is never done for any AUB.
Okay.
Saline infusion sonogram is optional. Even MRI is also optional, not for all the cases. Okay. So coming to the treatment part, how will you treat this case?
Because she's already 42 years and she's completed her family and she doesn't want to conceive anymore,
Yes.
and she's symptomatic, we can go for surgical management. And we can either go for hysterectomy or any myolysis procedure, or MR guided high intensity ultrasound can be used, or even uterine artery embolization can be done.
Okay. So here the definitive management is actually surgical management. Okay. There is no doubt in your case because she's a multiparous woman. She is one of the important investigation what we missed is a urine pregnancy test in your case. Pregnancy has to be ruled out because she is not tubectomized. Okay. So pregnancy related complications has to be ruled out in your case. That is one of the important investigation. Okay. And yes, coming to the treatment part, here there is no controversy at all. The treatment in your case is actually is going to be a hysterectomy. Okay. Only thing which has to be decided is which route of hysterectomy will be preferred depending upon the patient's choice and the surgeon's choice. Okay, whether you want to do abdominal hysterectomy, whether she wants to go for a laparoscopy, or whether she wants to go for a vaginal hysterectomy. Okay, so these are the options which are available. So the definitive answer for your case is actually hysterectomy. And medical management would have been required if she had any other coexisting anemia, or whether if she had any coexisting diabetes, hypertension, some systemic illness. If she had, maybe you could have mentioned even the medical management. Okay, to pull on for the surgery. But here anyway, actually she doesn't have any medical risk factors, and it is a clear cut case of a 16 weeks fibroid, symptomatic fibroid with finished completed her family, perimenopausal age group. Okay, so here it's going to be hysterectomy only. The answer is going to be only hysterectomy, only the routes. Okay, like whether you want to do abdominal, vaginal, or laparoscopy will change. Okay, so generally, can you do vaginal hysterectomy in this case?
Usually abdominal only, or laparoscopic.
So abdominal or laparoscopy is preferred in this case. Vaginal hysterectomy, generally it is avoided once the mass becomes abdominal. Up to 12 weeks, you can comfortably do a vaginal hysterectomy. But more than that, also a non-descent vaginal hysterectomy is done even for 16 weeks, 20 weeks masses also. But again, it is depends upon the surgeon's expertise. It is not commonly done. Okay, so generally abdominal masses are operated by abdominal route, either by laparoscopy or abdominal hysterectomy in your case. Okay, so just to discuss other medical management. So what are the medical management for AUB leiomyoma?
There are certain drugs used to reduce the bleeding, and certain drugs used to reduce the bleeding as well as size of the fibroid.
Good.
So drugs like tranexamic acid, progesterone, like mifepristone and ulipristal can be used to reduce the size as well as to reduce the bleeding. And anti-estrogen drugs like danazol, gestrinone, and letrozole can be used to reduce the size again. To reduce the bleeding, oral contraceptive pills can be used, or medroxyprogesterone can be used, and even levonorgestrel IUS can be used.
Yes.
And GnRH analogs can be used to reduce the size of the fibroid. And vasopressin is also used to reduce the bleeding.
Okay, vasopressin is not used in the preoperative patients. It is used only during surgery.
Okay.
Okay, it is not used preoperatively. It is not given orally or injections. It is not given to reduce the bleeding preoperatively. It is only intraoperative. Okay. Okay, so like you mentioned, so NSAIDs and antifibrinolytics both can be used basically to control the blood loss. Okay, but they don't have any effect on the fibroid size as such. Okay, NSAIDs and tranexamic acid antifibrinolytics are basically used for the symptom control, for the AUB control. Okay, and yeah, and combined oral contraceptive pills are generally avoided because fibroid has got both estrogen and progesterone receptors. Okay, but progesterone will help basically by reducing the AUB symptoms. Okay, so progesterones orally or injectables can be given, and even local progesterone, that is LNG IUS, okay, can be inserted for the symptom relief, but it is not helpful in a bigger uterus. More than 12 weeks, not more than 12 to 14 weeks of uterus, LNG will not be retained. The expulsion rates are higher because of the bigger cavity. Okay, so 12 weeks and lesser with AUB with leiomyoma, you can attempt giving a LNG IUS for the symptom relief. Okay, but they don't help in reduction of the fibroid size as such. Okay, so the definitive management in helping the symptoms plus reduction in the fibroids, okay, are actually GnRH analogs and okay, even mifepristone has been tried. So these three drugs have been tried, GnRH analogs. Okay, so GnRH analogs are
Uh, Leuprolide
leuprolide acetate, yes,
and
okay, gozerlin,
cetrorelix,
yeah,
goserelin.
gozerlin, naferlin. Okay, so leuprolide is commonly used, GnRH analog, and ulipristal acetate, okay, and mifepristone. So these three have been actually used to reduce the size of the fibroid, but the disadvantage is that actually the size will always come back. They tend to recur. Fibroids will recur to original size once the treatment is stopped. Okay, so that is the main disadvantage. So none of them are actually a clear cut management for fibroid because they definitely are not a permanent solution. They're temporary solutions when you want to buy time to correct her anemia. Like patient is anemic, but she doesn't want blood transfusions. Okay, our patient is having new onset diabetes, hypertension. She has got some other risk factors which needs to be managed before she goes for surgery. In those cases, you can try GnRH analogs or you can try even mifepristone or ulipristal can be attempted, but they are not the definitive treatment for fibroid. Okay, so the definitive treatment for fibroid will be surgery, either a myomectomy or hysterectomy. The other options will be, as you mentioned, uterine artery embolization and high intensity focused ultrasound. Okay, MRI guided high intensity focused ultrasound. Okay, so can you tell me about uterine artery embolization?
Yes, ma'am. Uterine artery embolization is usually done transfemorally. You inject polyvinyl alcohol, which reaches the uterine artery transfemorally, and it obstructs the blood flow to the fibroid, and it causes atrophy and devascularization of the fibroid. So it usually shrink.
Yes.
Uh, and because it can lead to uh, total atrophy of the endometrium, it is usually not done in people who want to conceive further and all. So once if they've reached around perimenopausal age, that time uterine artery ligation can be embolization can be done.
Yes, you're correct. Okay, so uterine artery embolization is definitely not preferred in cases of women who want to conceive. Okay, it is usually attempted only once a woman has completed her family because one is the chances of fertility is less and chances of premature ovarian failure. Okay, the chances of escape of this polyvinyl alcohol sponge material everything into the ovarian artery causing ovarian suppression, premature ovarian failure can happen. Okay, that is why uterine artery embolization is not done generally in the women who are keen to conceive. Now, it is not a fertility sparing option. Okay, it is done only for the perimenopausal women who are symptomatic, and generally it is done for the fibroids which are lesser than 8 centimeter. Not very large uteruses, you don't try uterine artery embolization. Again, there the management will be surgical. Generally 6 to 8 centimeter or 4 to 6 centimeters will be the ideal masses for the uterine artery embolization. Okay, and what about high intensity focused ultrasound?
Again, high intensity focused ultrasound is like the patient is usually placed in that MR machine, and for around 2 to 3 hours, there's high intensity ultrasound waves being projected on the fibroid, and it causes atrophy or it causes necrosis of the
Yes.
myomas. And again, because it can destroy the uterine tissue, it's usually not done in people who want to conceive again. And it also cannot be done if the abdominal size is more than 24 weeks, or if the fibroid size is more than 10 centimeter.
Okay. I thought actually high intensity focused ultrasound can be done in women who want to conceive later. Okay, high intensity focused ultrasound. It's an option in the women who are keen on conceiving. Okay. You're sure that it is not done in the women who want to conceive? Let me check on that. Okay, we'll check on that. Okay. Yeah. Again, that is also not suitable for a large uterus. It is usually uterus with less than 12 weeks, around less than 8 centimeters only. Okay. It is definitely helpful in reducing the size of the myoma and also bringing down the vascularity of the myoma. Even symptoms also will improve. Okay. And how ulipristal helps here? It's basically a selective progesterone receptor modulator. All the hormone therapies like androgens and progesterones, antiprogesterones, both will help basically by reducing the receptors on the fibroid. Okay, there is some reduction in the size, but again they recur once the treatment is stopped. Okay, so yeah, coming to the conservative management. So when you are planning to, there are other options like myolysis or cryotherapy which are not used. Okay, so let us discuss about myomectomy. Okay, so what are the when you do myomectomy?
Myomectomy is usually done if she wants to preserve her reproductive function, or and she wants to, if the size is if there's only a single fibroid, then you can do myomectomy. And if there's no other associated pathologies in in the endometrium, and then we can do myomectomy.
Yeah. So generally, myomectomy is reserved for the women who want to retain their fertility, and also in young women who want to retain even menstrual function. Like women less than 40 years, you can go for a myomectomy, though they have completed their families. Okay. So in those cases, we do, and myomectomy is done only for the symptomatic fibroids. So infertility women with fibroid doesn't mean that you have to do myomectomy. You have to rule out all the causes for infertility, like factors, husband factor, ovulation factor, AMH, everything, all the other factors are normal. In those cases, once you know that it is actually idiopathic infertility, then you can go ahead and do a myomectomy, because there are many women who conceive with large fibroids. So fibroids may not affect the fertility at all. Okay, that's what many claim. Okay, but there are many incidences like many women conceive even after doing myomectomy, though who have never conceived before. Okay, so 40% of the women conceive, infertile women conceive after doing myomectomy. Okay, so it can happen. Okay, so myomectomy is still an option for women with a idiopathic infertility. It can be done. Okay, so what are the prerequisites for? And even when you are doing for any other symptomatology, like patient is coming with AUB who has completed her family, but she wants a myomectomy in a younger patient. In those cases, also you have to rule out other causes for AUB. You have to do an endometrial biopsy. You have to do a Pap smear. You have to rule out other causes first, then you proceed with the myomectomy. That is important, which should be kept in mind. Okay, because myoma could be just a incidental finding. Okay, like tell me what are the clinical features of fibroid myoma?
The menstrual symptoms like menorrhagia and dysmenorrhea. They can also present with infertility, uh, and pain abdomen symptoms if there's complications of fibroid like degenerations or red degeneration, torsion of the leiomyoma. And they can also they can have associated features like PID and endometriosis that can also produce pain.
Yeah.
And they can
Uh,
also have associated endometrial hyperplasia.
hmm. Yes. Okay. So menstrual disturbances, pain abdomen, okay, pressure symptoms, and remember even fertility related, infertility, and what are the clinical features when they're present with pregnancy with fibroid.
Yes.
Okay, abortions, recurrent pregnancy loss, or it could be obstructed labor. So when you're telling clinical features, important thing is what you have to mention. First thing, what you have to mention is 50% are asymptomatic.
Yes.
Okay, they're found on incidental examination, either when they have got an ultrasound for some other reason or when they have been examined for some other reason. Like they have come for a routine pap smear screening, you diagnose that she's having fibroid uterus. Okay, so it's an incidental finding. So 50% of the women are asymptomatic. That's the first thing you write in clinical features. Okay, then comes like other menstrual complaints. Any type of menorrhagia can come. Heavy menstrual blood loss, acyclical bleeding, intermenstrual bleeding because of the polyps. Okay, abnormal vaginal discharge, dysmenorrhea. Okay, all the menstrual complaints can happen. Okay, and then mention about the pressure symptoms. Okay, difficulty in passing urine, like large cervical fibroid, sudden acute retention of urine, constipation. Okay, all those things can happen. And abnormal vaginal discharge, like even mass per vagina. Okay, it can happen. Why intermenstrual bleeding in polyp? Okay, intermenstrual, yeah.
If there's any ulceration of the mucosa of the polyp, or if the fibroid is a pedunculated fibroid is
Hmm.
presenting as mass per vagina, that can produce intermenstrual bleeding.
Yes, good. It's mainly because of the surface ulceration of the polyp. Okay, intermenstrual bleeding is actually because of the surface ulceration of the polyp when it is trying to get extruded from the uterine cavity. Okay, yeah. So menstrual complaints you have to mention pressure symptoms, vaginal symptoms, and mention about the fertility related. Like they can present with infertility, or they can present with the recurrent abortions, recurrent pregnancy loss, and or even the pregnancy with fibroid. Okay, like abruption can happen, postpartum hemorrhage. There can be obstructed labor. Okay, so all these clinical features should be written when you're writing the clinical features. Okay, and what is the cause of menorrhagia in fibroid? As I mentioned, most of the time they're asymptomatic, right?
Yes,
So which type of fibroids usually present with menstrual bleeding?
submucous type of fibroid.
Closer to the uterine cavity, more will be the menstrual symptoms.
Yes.
Okay, so submucosal, large intramural fibroids present with menstrual complaints generally. Okay, subserosal fibroids generally present as mass per abdomen or pain abdomen like that.
Okay.
Okay, yeah. So what is the cause of menorrhagia in fibroid?
Because the surrounding uterus is hyper contracted and trying to expel the fibroid. That is one reason, and because of hyperestrogenic state, the endometrium is very thick and very fragile.
Yes.
That is one more reason, and also because of increased surface area of the endometrium,
Hmm.
there will be heavy menstrual bleeding, and there's pelvic congestion, and all the blood vessels will be congested in the uterus.
Yes. Yes, good. Okay. Yeah, increase in the surface area, increased vascularity, increased pelvic congestion. So increased vascularity is basically arterial blood supply. Increased pelvic congestion is because of the tumor compressing on the veins.
Veins.
Leads to congestion. Yes, and associated hyperestrogenic condition, or it could be associated endometrial hyperplasia or malignancies. Okay, and theoretically it can interfere with the uterine contractility. Large fibers can interfere with the uterine contractility. Okay, so these are the causes. What is the cause of pain in fibroid?
Pain can be
Painless tumors.
it's
Right?
either because it can undergo torsion,
Hmm.
or during pregnancy, if it's a red degeneration, that can produce pain,
Yes.
or if it's associated with endometriosis or PID.
Hmm. Yes.
And
Yes.
if a submucous polyp is protruding towards the cervix,
Yes. When it is trying to become polypoidal, like intramural is becoming submucosal and polyp. Okay. Yes. Then yes. So these are the important causes for pain. Most of the time, fibroids are actually painless tumors. Okay. Common causes is actually degenerations. Okay. Red degeneration and sarcomatous degeneration is the cause for pain. Like postmenopausal woman who is known to have a fibroid has suddenly come with pain abdomen. You have to suspect sarcomatous degeneration. Okay. So degeneration is one of the common cause. Then followed by like when it is becoming submucosal and polypoid. When it is becoming polyp, when the uterine contractions are there, when the intramural fibroid is becoming submucosal and a polyp, in that case it can become painful. Okay, or other rare causes include actually torsion, infection, hemorrhage. When the pedunculated fibroid polyp undergoes torsion, or when there is a secondary infection of the submucous fibroid. Okay, there is an infection, or when there is a hemorrhage into the capsule. Okay, they all can lead to pain. Okay, again the other causes for pain will be pressure symptoms, or it could be associated with endometriosis or adenomyosis. When there is associated endometriosis and adenomyosis, fibroids can cause pain. Okay, yeah. So we were discussing actually about myomectomy, right? Yeah. So
yes.
when you're planning for a myomectomy, always keep in mind that you have to rule out other causes for that symptoms, whichever complaint patient has come for. Like she has come for infertility, or she has come for AUB. or she has come for recurrent pregnancy loss, other causes of other differential diagnosis has to be ruled out before going in for myomectomy. Okay, because fibroid can be just an incidental finding. That should be kept in mind. Okay, yeah. So what are the important prerequisites for myomectomy?
First, anemia should be corrected and blood should be arranged.
Yes.
And you should, before when taking consent for myomectomy, we should also take consent for hysterectomy,
Hmm.
because there are chances that if there's severe bleeding, they can convert it into hysterectomy.
Yes.
And endometrial biopsy should be done to rule out any endometrial carcinoma.
Hmm.
And we should rule out any other causes of infertility or any tubal blocks.
Yes.
And also the examination of the husband, semen analysis should be done
Yes.
to rule out infertility because of the husband.
Hmm. Yes, good. You have covered almost all the points. Okay, hemoglobin has to be 12 grams and above. Okay,
Yes.
and if the patient is insisting about auto transfusion, like she doesn't want to take blood transfusion from others, she can give her own blood sample. She can do autologous blood transfusion also. She can give her blood, and after 1 week she can undergo her myomectomy. That can also be done. And generally, 2 packed blood cells should be cross matched and should be kept ready. Okay, the important complication of myomectomy is actually hemorrhage, right? Okay, so blood should be kept ready, and all the causes uh, for her condition, for her symptoms should be ruled out first, okay, before proceeding to myomectomy. Okay, and what are the measures which can be used to control the blood loss during myomectomy? And you mentioned about the consent. Yes, you are correct. You have to take the consent for hysterectomy. That is important. And other option is doing a proper mapping of the fibroid. Whenever you're planning for a conservative management like myomectomy, do a proper mapping of the fibroid either using an ultrasound or a MRI. Ultrasound, like 3D ultrasound, also will give you a good, clear picture about mapping, like what is the distance from the endometrial cavity, whether we have to open the endometrial cavity or not. Is there any presence of small submucosal fibroid or not? Okay, and number, location of the fibroids. Okay, particularly you can make out lateral wall fibroids are difficult to do a myomectomy because you'll be interfering with the uterine artery and reconstruction of the uterine wall. Okay, so lateral wall fibroids, so all those things and vicinity to the uterine artery ureter, they can be made out. So that is mapping of the fibroid is important before going in for a myomectomy. Okay, and all the other things you covered. Okay, good. Yeah. So what are the measures to control the blood loss during surgery, pre or post op, intra-op?
Usually, the surgery will be usually planned in the post-menstrual,
Yes.
post-menses period,
Hmm.
and they give GnRH analogs can be given to reduce the vascularity of the tumor,
Yes.
and vasopressin is given over the surface of the myoma uh,
Yes.
to cause vasoconstriction,
Hmm.
and anesthesia, hypotensive anesthesia is usually
Yes.
uh, given. And during the surgery, uterine artery ligation can be done either by by tying tourniquets, or
Good.
with bony clamp can be done. If the surgery is going for more than 45 hours, you have to intermittently release the ligation.
45 minutes. Okay. Yeah. Hmm.
And
Yes, good. Okay. So pre-operatively, you can use GnRH analogs. Okay, that is the important thing. One thing is the advantage of GnRH is it reduces the bleeding and
and
it also shrinks the size of the fibroid.
yes.
Okay. Like if you're planning for a hysterectomy also, if there's a large 32 weeks big tumor, okay, instead of giving a big vertical incision, you can give GnRH analogs. You can shrink the size of the fibroid to 20-24 weeks. You can do a small Fenton steel incision. Okay, our patient, instead of going for abdominal hysterectomy, she can go for a laparoscopic hysterectomy. Okay, so GnRH analogs are important. Is one thing is it will definitely reduce the size of the fibroid. It shrinks the size of the fibroid so that the route of the surgery can be altered. Like instead of doing a large incision, you can you can remove the uterus in a smaller incision, or you can go for a laparoscopic management. That is the advantage of giving GnRH analogs. Okay, what is the disadvantage of giving GnRH analogs preoperatively?
Usually the pseudo capsule will help in differentiating from the uterus. It'll obliterate the pseudo capsule, so it becomes hard to enucleate the fibroid.
Okay, so theoretical possibility is that the dissection can be difficult, but most of the time they do not. Okay, the main disadvantage is that when they decreases the size of the fibroid, the smaller fibroids like 1 centimeter, 2 centimeter fibroids tend to disappear. So when you're doing myomectomy, you cannot make out the smaller fibroids. Okay, but once you have finished the myomectomy, later in 2 or 3 years, she is going to have a recurrence of fibroid. Okay, so smaller fibroids tend to disappear because of preoperative GRH, which can be missed during myomectomy, which can cause recurrence later. So, okay, that is the main disadvantage of using GRH analogs. Okay, but they're actually very good in reducing the blood loss. Okay, and even in avoiding the blood transfusion. Okay, because blood transfusion itself can have many complications, right? So patient can avoid blood transfusions by giving a GRH analogs in the preoperative period. Okay, that is the advantage. But disadvantage is again, as I mentioned, the recurrence rate, and important thing is cost. They're quite costly injections. Okay, the single dose itself usually will be around 3 to 4,000. Patient has to take at least 3 doses generally. Okay, they're quite costly injections. That is why they're not used. Okay, so coming to intraoperative measures of controlling the blood loss, you mentioned all of them. Hypotensive anesthesia, generally it was used for cardiac and cranial surgeries. Nowadays it's used even for myomectomy to reduce the blood loss. Hypotensive anesthesia can be used, and the commonly used drug which is generally used for myomectomy is actually vasopressin infiltration. Okay, 20 units in 200 ml saline. They use a saline with a vasopressin installation, which can be instilled throughout the fibroid and also the base of the fibroid. It can be instilled, and that will help in reduction of the blood loss. Vasopressin is used. Noradrenaline and other drugs are not used because vasopressin acts for a longer time. Okay, so 20 to 30 minutes will be the action. So you can finish myomectomy by that time. Okay, so vasopressin is commonly used. Other methods are actually uterine artery ligation or use of a tourniquet or a infant feeding tube around the uterus so that uterine artery gets occluded. That can be done. Okay, so these are the commonly used measures to reduce the blood loss during myomectomy. Okay, so can you briefly mention about the procedure of myomectomy?
No, I don't know exactly in detail.
Okay. Okay. So I'll not go into the details of procedure. It is not required. Only the main important steps. Okay. So usually number and location of the fibroid both are not contraindications. Okay. As many as 200 myomas have been removed in single surgery. Okay. So number and location both are not contraindications for myomectomy. So as many fibroids as possible can be removed in a single myomectomy procedure. And you can do even hysteroscopic myomectomy if the myoma is completely submucosal. Okay, it can be done. Even hysteroscopic myomectomy also can be done. You can do even laparoscopic or open myomectomy. Okay, what is the meaning of fibroid mapping? So fibroid mapping is you are exactly locating number, location of the fibroid can be made out, and the distance from the endometrial cavity will be made out. Okay, many times when you're doing laparoscopic myomectomy or when you're doing a hysteroscopic myomectomy, you will not know the presence of other myomas. You cannot make out the presence. If you have opened, you can always feel the uterus and you can know even the smaller fibroids. But that may not be possible in laparoscopy or hysteroscopy, or even smaller fibroids may be missed. Okay, so when you're doing ultrasound, do a thorough ultrasound and make out the distance from the endometrial cavity, or even in the MRI also, whether the distance from the MRI from the endometrial cavity, whether it is anterior, posterior, lateral. It's actually mapping is nothing but the exact location and the distance from the serosa and the endometrial lining can be made out. That's what you mean by mapping. Okay, like including smaller fibers will be included in your mapping. You write a picture so that you keep that picture in when you're doing surgery so that you will know, I mean, where exactly you are making the incisions and you're removing the fibroids. Okay, so that is mapping. Okay, so in myomectomy procedure, yeah, so number and location both are not contraindications, though lateral wall situated on the uterine artery are actually slightly difficult to remove and reconstruct. Okay, so usually anterior incisions are preferred, but you can make posterior incisions also, but the risk of adhesions is slightly higher with the posterior incisions. Okay, and as far as possible with the single incisions, remove as many fibroids as possible. Okay, so like there are 4 to 5 fibroids on a uterus. You don't make 4 incisions on each fibroid to remove the 4 fibroids. Okay, with a make the incision inside the cavity, that is tunneling incisions. You call it as a tunneling incisions. You don't make multiple incisions on the surface of the uterus, so that you can avoid adhesions later, and also blood loss will be reduced. Okay, so that is called as tunneling incisions. You make a single incision. With a single incision, as many fibers will be, as much as possible, will be removed, making a tunneling incisions. Okay, and the possibility of a submucosal fibroid, small submucosal fibroid should be known before doing a surgery. That also should be removed. Okay, and then comes the hemostatic sutures. Okay, the fibroid bed is sutured with the mattress sutures for complete hemostasis, and the surface, the superficial surface of the serosa of the uterus is actually sutured in the baseball sutures, so that sutures, not much of the suture material is not exposed outside, to reduce the, and it will reduce the risk of adhesions. Okay, so main steps of myomectomy, what you have to remember is, one is control of the blood loss during surgery, either using a vasopressin or by a tourniquet. Okay, and second thing you have to remember is that anterior incisions are preferred compared to posterior incisions. Okay, and make minimal number of incisions and make tunneling incisions to remove as many fibers as possible. Then put a proper hemostatic sutures, that is mattress sutures in the bed of the fibroid, and baseball sutures in the superficial serosa. Okay, so hemostasis should be completely secured. So this is about the myomectomy. Okay, and you mentioned even about the clamp, myomectomy Bonis clamp. Okay, myomectomy clamp also can be used to reduce the blood loss. Okay, yeah, baseball. It's not baseball, baseball. Okay, baseball. If you see a baseball, you can make out only small line on the this thing. Okay, so here the most of the suture material will be taken inside out. I mean, most of the suture material is inside, is below, like subcuticular stitches. No, most of the suture material is below the serosa. Not much of the suture material is exposed to the peritoneal cavity, so that adhesions are reduced. Only small line will be seen. Okay, that is baseball sutures. It's a baseball. It looks, the suture line will look like on the line on the baseball, the stitching point on the baseball. Okay. Yeah. In the exam, generally they ask about clinical features of fibroid, how fibroids cause menorrhagia, how I mean, what are the causes of pain in fibroid, and management, medical management, as you described, management for the AUB symptoms, and a conservative management like myomectomy, and hysterectomy. Like few students will also they'll also ask what are the steps of hysterectomy, which is standard steps of hysterectomy, which you write generally in the logbook. Okay, so important steps you should remember. Okay, so these are the general questions in the fibroid. And degenerations, they rarely ask what are the types of degenerations in fibroid, what do you mean by red degeneration. Okay, these are the smaller questions which you can read it in the textbook. It's quite straightforward answers. Okay, any other doubts you have in fibroid? Anybody, anything else?
If there are doubts, please put them in the chat section. Ma'am will clarify.
Can you please repeat ultrasound in fibroid? Yeah, so ultrasound in fibroid, the reason, okay, what all things you can know in ultrasound is, you can know the number of fibroid, location of the fibroid. You can differentiate fibroid from adenomyosis, and you will also know associated endometrial thickness. Okay, and even small polyps can be made out. Okay.
If there are no more doubts, we can conclude the session.
Yeah.
Thank you so much, ma'am. It was
Yeah,
indeed
thank
a
you.
comprehensive clinical class. We could learn a lot from the discussion, ma'am. It was amazing discussion. And now, from December, all the colleges will be reopening, and we all seek your blessings, ma'am. And thank you for your guidance, ma'am.
Thank you. Yeah, and
Thank you, ma'am.
thanks, Rekha. It was a nice presentation. Thank you.
Thank you, ma'am.
Yes. It was a great presentation by Ms. Rekha. We could learn a lot from your well-prepared presentation. Thank you. And I thank all the
One
participants.
last doubt is there. Yeah, sorry, Pallavi. They
Yes,
have
ma'am.
asked what is the risk of PID in fibroids. There is no risk of PID in fibroids. Okay, thank you.
Yeah. Okay. I thank all the participants for their active participation.